Hello everyone, this is Chadi from Arch 2023. I'm really privileged today to be with Dr. Jimmy Kerrigan. He is a phenomenal interventionist, a colleague, and has been a pioneer in imaging and physiology. Jimmy, thanks for being with us.
I'm happy to be here. Always good to be here with you. Always good to be here at Arch in St. Louis, a conference that's been around for a very long time and I think is affecting the lives of patients, of providers, and fellows in the region and nationally.
Thank you so much.
Good to be
Absolutely.
here.
Yeah, thank you. So you gave a phenomenal talk about left main, but also you have a series of talks about physiology and imaging in general. We're still in a time now where some operators still questioning the value of these two tools. Why is that?
You know, I think that the reasons that people don't use imaging specifically, it takes too long, it costs too much, it doesn't matter, or I don't know what I'm looking at. I think that as we whittle away, especially at the data aspect of things, we have a lot of information that comes from various trials, ADAPT-DES, IVUS XPL, the ultimate trial, that show that you do improve outcomes for patients who are getting intervention. A lot of the time the intervention that we're doing does not improve mortality, so we better be doing a really good job of doing that using the technology available. But the indictment of that data is that it's outside the United States, Chinese and Korean data. So Renovate Complex PCI just came out looking at complex intervention showing a mortality benefit for patients when you use intravascular imaging, but it's outside the United States. I think that what we need to move this space forward is American data. Illumian 4 and the improved trial, should they show a benefit, which we hope that they do because we think that this is the right thing to do, will hopefully garner a 1A recommendation like we have for radial intervention, and then hopefully will then drive compliance or at least more of a consideration for the utilization.
Yes, especially like performance evaluation or be a KPI part of the metrics for the cath lab.
Quality outcomes metrics and even potentially reimbursement in the future. If you're doing intervention without imaging, then potentially either penalize or ideally give somebody an incentive to do imaging. So then you've conquered a couple of the issues from an administrative and cost standpoint if you achieve that. Now it comes down to education of physicians. Yes. Do you truly understand what you're looking at? Jazz and others at this conference, others around the country and the world, and I don't pretend to be one of them, have spent a lot of mental effort in trying to educate physicians, starting at the fellowship level, all the way through physicians who have been in practice for 20, 30 years, to understand the importance of intravascular imaging, the image interpretation, how to use it to size a stent, decide if you need calcium modification, how can we improve outcomes for our patients so that they live a long time and feel very well doing it.
Yeah, without re-intervention or bringing back to the cath lab for an ISR or something else.
Absolutely.
So fellows, you touched on it briefly before we went live, is important assets. They should taught properly, imaging and physiology. What are you doing and Arch doing for that?
Yeah, so I think that somebody said it quite well in one of the earlier sessions. Fellowship is an apprenticeship, and you're only as good as the person from whom you learn. If I'm a plumber and I learn from a plumber who doesn't know how to put in a toilet, I'll never know how to do it. I think that's where conferences like this, with Arch, other conferences through CRF, through OPCI, through other organizations that are focusing on making sure that the next generation of physicians are facile with all of the technology available. It's not just imaging and physiology, things like atherectomy devices, lithotripsy that they may have no access to. Making sure that when they leave their training programs, they feel confident and competent with the technologies that are available so that when they go into practice, they're fully prepared to do what's best for their patients.
And they know what they're looking at.
And know what you're looking at, feel confident in looking at it. And that's why I also encourage when I'm speaking with physicians who are teaching, make sure that the fellows actually have that opportunity. They're the ones that are measuring. They're the ones that are picking the balloons, the stents, deciding whether or not there's atherectomy. Of course, with a rope, don't let somebody do something silly or dangerous, putting a 4.0 stent in a 2.5 vessel. But at the end of the day, giving enough rope to learn and to grow. And again, in practice, when there's nobody standing to their left anymore and they're making the decisions, giving them the tools they need to succeed.
Absolutely. Well, Jimmy, you said it well. You said it perfect. There's no excuse for operators not to use physiology and imaging, especially with the data we have so far. I know we need US data, but we have a lot of data OUS, which can adjudicate and for the power of these two tools.
Yeah.
Jimmy, thank you so much for your time.
Chadi, always a pleasure.
We'll see you in Arch 2024.
That sounds perfect.
Thank you so much, everybody, for watching this. See you on the YouTube channel. This is Chadi from St. Louis.